I think they should be aware, number one, of their deployment history and get a good deployment history. There are clearly individuals that have had, other than the generalized exposures, everybody gets exposed to the dust that's over there. Everybody's been around a burn pit. Now, not everybody's working with a burn pit, but they're around the smoke. Depending on where they deployed, some areas that you go over, the air is great because you're out in the middle of the desert. The other areas you're in, there's a lot of pollution. So identifying, the generalized exposures, but also specific exposures. One of the guys that I saw that we found some changes on, his job was recovering the vehicles that got burned, that got blown up. So he was around a lot of smoke and dust. Another guy had very significant symptoms related to airplane crash recovery. So there was a lot of smoke there. Another guy was in a building where there was chemicals, and the chemicals, there was an RPG round, blew up, and injured his lung. So to be aware that they may have some different exposures. To be aware that, there's a lot more smoking in our population than in the general population. And trying to tie that back, did the symptoms start with deployment? Because if you talk to most people over there, and the studies have shown this, there's a lot of people with respiratory symptoms. Most of them go away. People talk about the crud that they cough up. And trying at least to do a good evaluation, not to just say, oh, it's just asthma. Because a lot of people think, you have a young person, they're short of breath, oh, it's asthma. I mean, even within our system, we see a lot of that and try to, but to think about the unusual things, think about the different things, and at least do a basic workup to say, hey, it's not this disease, not this disease, it's not this disease, before you pawn it off and say it's asthma. So I think probably the best thing is, and what the occupational medicine folks do, is get a very good deployment history and try to pinpoint exactly when symptoms started, or try to relate them back to deployment, whether or not that's true. I don't know. It's very hard. I've seen a lot of these guys and talked to a lot of these guys, and most of them don't have any very specific exposures, but a lot of them have been around all the other stuff. And I think in selected individuals, it's going to cause disease. Probably most people it doesn't. But then you have to, for instance, if they've been lifelong smokers, is it the smoking or is it the deployment? And personally, I think, the smoking can cause a lot more problems when you're inhaling cigarette smoke on a daily basis and all the things associated with that. I mean, there are other challenges. I mean, we also do critical care. So clearly our role, during the heaviest fighting was taking care of the patients that were critically injured, both on the battlefield, at launch stool, back here as well. So that's another one of our roles. We did a lot of that. So acutely, that's the problem. I think trying to fully evaluate these patients. We don't want this to turn into another, for instance, Agent Orange, where people are coming back a lot of years later. And it's very hard to determine, did this illness relate back to this, this exposure there, and what was the exposure? But to address the issue now, to get a good handle in the medical literature now on what we're seeing, what the types of disease are. And so as people come back and may have, perhaps, and we'll see if they have complaints 10 years later, that we've done an adequate job. The thing I want to see most is that those patients with complaints get an adequate workup, not as comprehensive as I'm doing, but get an adequate workup to say that at least at this point in time, we didn't find this, or this, and do the basic things that a pulmonologist would do, instead of saying, oh, don't worry about it, come back later. And addressing these issues, I've been very surprised at, for instance, individuals who have gone 4 or 5 years and have never made it up to our level to get seen. We don't know the extent of disease, and if we don't see the patients, we'll never be able to sort of determine the extent of disease. So the nice thing about Stampede is that people are now hearing about it. I mean, all my colleagues in the Army and the Navy and the Air Force know about it. And so they are, and patients know about it through Military Times and articles like this, and so they are, calling us up, wanting to get seen, and at least we can tell them when they leave, this is what we found, this is what we didn't find. We're not always able to fix their problems. It's one of the problems with lung disease is you can, for instance, COPD, we can make them less symptomatic, but we don't make it go away. But at least we can give them a good baseline and say we've done a lot of things.